So our next speaker is Dr. Dane Genther. Dr. Genther is a facial, plastic, and reconstructive surgeon and otolaryngologist, a head and neck surgeon. So Dr. Genther specializes exclusively in plastic surgery of the face, head, and neck, and performs full breadth of reconstructive, cosmetic, and functional procedures. Through many years of experience and extensive training, he has gained experience in the treatment of facial movement disorders, including facial paralysis and synkinesis, skin cancer reconstruction, and revision nasal surgery rhinoplasty. Dr. Genther graduated with honors from the University of Michigan Medical School. Then he completed a residency in otolaryngology, head and neck surgery at Johns Hopkins University. Following this, he did further fellowship training in facial plastic and reconstructive surgery at Johns Hopkins University and Oregon Health and Science University. Throughout his surgical education, he spent years learning from and training with several world-renowned experts in the areas that he now treats. And so Dr. Genther will be speaking to us about surgical nerve solutions for patients with neurofibromatosis and schwannomatosis. So thank you very much.
Hi, thank you very much. My name is Dane Genther, and like it was just introduced, I'm a facial plastic and reconstructive surgeon here at the clinic. One of my areas of specialty is treatment of facial nerve disorders, specifically called facial reanimation. There's various components to it, but I'm going to talk about the surgical options. So why does facial movement matter? So several reasons. One is it allows us to express ourselves and connect with others. Social interaction is a very important component of daily life. A second major component is to protect the eye through blinking and closure. We take this for granted, but every minute, several times, our eyes blink spontaneously to keep our cornea moist, keep it from drying out, and to make sure our vision is healthy. Additionally, we can sleep clearly and comfortably, eat and drink with confidence, and feel like ourselves again. And the important thing to realize is that while some of these movements are obviously visible, they're not cosmetic. Sometimes they're brushed off as that, but they're very functional and vital to our identity. So why does facial weakness occur? So several reasons. When it comes to a facial nerve tumor, it often involves invasion of the tumor, the nerve by the tumor. Additionally, during surgery itself, during treatment, sometimes the nerve has to be damaged or partially removed. And then radiation, which is an option for treatment for some of these tumors, can cause dysfunction as well. And the key concept with facial nerve movement is that it's a system. So you have a brain, a nerve, and a muscle. The muscles depend on a nerve signal to stay active and healthy. Without nerve signals, movement gradually fades, and over time it can't be replaced or restored in the common fashion. So how does facial movement work? So you have your brain initiates a signal with the goal of a specific movement. The nerve is really the conduit that carries that signal, and then the muscle responds by initiating the movement. And if any aspect of this is disrupted, then facial movement is affected. So how do we choose treatment for patients with facial weakness? So it depends on the degree of facial weakness. Sometimes it's mild and moderate, and you can do small, non-invasive procedures in the office, or sometimes it's more severe and it requires surgical intervention. And I'll go through those in more detail here. A big component of facial nerve rehabilitation beyond the surgery itself, which we won't discuss today, are facial retraining with facial physical therapists who has expertise in facial nerve movement. And then we have to consider the health and viability of the facial muscles. There's options to restore the nerve and the muscle, and each treatment depends on the patient's specific circumstances. And then also, obviously, in consultation with the patient, the priorities and expectations come into play. Every treatment plan is individualized. Two patients with seemingly the exact same condition will have very different treatment plans, depending on their specifications of their condition and their desires. And this requires a surgeon with specialized training and expertise in facial reanimation. While this field is becoming more widespread, it tends to still be isolated to larger institutions in terms of the higher level of expertise. So a consultation with one of these surgeons is especially helpful. So there's three categories of facial reanimation treatments. The first is a nerve transfer. So this is useful when the facial muscles are viable, meaning that they have the capability to move, they just need a new signal. This is most often in recent paralysis events, where the nerve input has been severed or damaged somehow, and the muscle is waiting there essentially for a new nerve signal. Muscle transfers are useful when the muscles are no longer viable. This is often in the case of long-standing paralysis. In this case, we can restore both the nerve and the muscle, but after a period of approximately 2 years, the muscles in the face become non-viable and must be replaced with a fairly complex procedure, but I'll kind of break it down and I'll show an animation that demonstrates it well. And then along with these, we do static procedures. So the first two are dynamic procedures that are meant to restore movement. The secondary procedures are called static, and that's essentially meant to support the face during rest, improve eye closure, and improve symmetry. And they're often combined. Nerve transfer surgery, like we talked about, when the muscle is healthy but the nerve signal has been damaged, we can use a nearby nerve to restore signal, restore function. There's a variety of different nerves. I'll talk about the most common one in the next slide. It works very well to restore the smile. But again, this is most important when the facial nerve injury has been recent and the muscles are essentially waiting for a nerve signal. So the masseter nerve transfer, the masseter nerve goes into the large chewing muscle of the cheek. We can borrow that nerve and hook it up to the nerve that controls the smiling muscles. It's a very strong and reliable signal. It's a bit of a process. It takes time for the nerve to grow in, for the muscle to respond, and the brain adapts over time. So it's essentially akin to an automatic car versus a stick shift. An automatic car, you sit down, press on the gas, and the car goes. That's sort of a spontaneous, natural smile. With a stick shift, there's a few more things involved with your hand and your foot that seems unnatural at first. So it's difficult at first and patients often stumble, but over time with practice it becomes second nature. And if you've driven a stick shift, after a few years you can eat your lunch and talk on the phone and drive at the same time without really thinking about it. And that's sort of the analogy of how a masseter nerve works. It's not natural, but it can become natural over time. And in terms of healing, the first few months after healing, the nerve is still growing in, so you don't expect movement. Once the nerve starts to grow in, the movement is subtle. It'll be weak at first, just a small twitch movement, and then strengthen over time. When that movement starts to become stronger, we initiate physical therapy, just like you would for any muscle in the body that needs to be reconditioned. And it takes approximately 6 months to 2 years to really get to the point where it becomes as strong as it can be, and you can really figure out how to use that signal, again, just like the stick shift. And this is an example of a masseter nerve transfer. So on the left, this is her attempted kind of snarl and then a smile here, so there's no movement. And then now after a masseter nerve transfer, this is about a year after, so here she's trying to smile gently, bigger smile, no movement, and now she's biting down. You can see the movement initiate on the left side of the face. So while it's not perhaps back to what we would call her previous normal smile, often in these situations we seek a new normal, where the goal is not to restore the exact movement that was present before, but more to balance the face, get it to be more symmetric, and more socially interactive. So the gold standard when treating facial paralysis, this is useful particularly when the facial muscles are no longer viable, but in certain situations it can be done earlier. So we take a small muscle from the inner thigh, transfer that to the face. We find a nerve to power that, which I'll talk about in a moment, and then we hook it up to blood vessels to make sure it stays healthy, and then we give it time to heal. And this initiates a new smile. We can customize this to the patient depending on the smile on the opposite side. So some patients have a small Mona Lisa smile where you don't see many teeth. That's totally normal and acceptable. And some patients have a full denture smile where you can see all of their teeth. So we try to take this into consideration when doing this surgery. There's multiple nerves that can power this muscle. We almost always use the masseter nerve, that chewing nerve, when possible. And additionally, we can do what's called a cross-facial nerve graft that I'll show in the next animation. And that borrows signal from the good functioning side with the benefit of having some spontaneity to it, since it's initiated on the good side when the smile muscle is activated, and that nerve signal is transferred to the opposite side. Okay. So this is a gracilis. It's two-stage procedure. So the first, if we use a cross-facial nerve graft, we take it typically from the leg. There's other locations, but the leg is the most common. And we hook it up to the good side of the face, transfer it over to the affected side, and give it time to grow, typically 6 to 8 months. So you can see it connected to the good side and tunneled over to the affected side, give that time to grow in. And then stage 2 is the actual gracilis muscle transfer itself. And this can be customized based upon the smile. We have different vectors of smile. We try to elevate the corner of our mouth, elevate our upper lip, and have the lower eyelid crinkle as well. It's called a Duchenne smile. The most recent innovation is that what we call vectors. So the first vector there you can see is your bigger smile, upper lip elevators, and then the lower eyelid is most recent innovation in terms of getting it to look more spontaneous and natural. People often say you smile with your eyes, and that's because literally your eyes move when you have a spontaneous, happy smile. And I'll show that in a few patients here. This can be done in children and adults. This is just some of the more kind of meaningful examples. This is a young girl who had an early facial paralysis event, and on the right, you're going to see with a cross-facial nerve graft and the masseter nerve, restoration of her smile. So in particular for her, the lower eyelid contraction is very meaningful. Again, it looks more natural, looks spontaneous, and it's more of an emotive smile. This is another young boy with bilateral facial paralysis. Unfortunately, this is him attempting to smile prior to surgery. We used his masseter nerve and did gracilis procedures bilaterally, and this is his new smile. So again, he has some of that lower eyelid contraction. He's able to express himself, and it's a very meaningful change for him. And then in terms of those static procedures, the two areas that we tend to focus on are the area around the eye and the corner of the mouth. So for the corner of the mouth, we can often take some tissue from the thigh and use that to essentially form a sling to elevate the upper and lower lip and the corner of the mouth to a more natural position, so at rest it's not drooping. And then in terms of rehabilitation around the eye, we focus on the eyebrow, which can be elevated through a number of techniques to have it match the other side. We can assist with upper eyelid closure, which is important to keep the eye healthy. Most often we do this with an eyelid weight, a small gold or platinum chain placed under the skin, which through gravity assists with closing the eye. And then occasionally the lower eyelid will droop as well, and there's ways that we can tighten this up. So in reality, we often have a fairly comprehensive combination of all these different procedures, often dynamic with static, and within those categories, there can be several combinations. It's a staged reconstruction over time, meaning that it's not a one-and-done situation. It's more of a project, meaning that we'll focus on primary concerns, sometimes with the bigger procedures first, and then we'll augment down the line. In other cases where it's a more minor condition, then we can do the smaller procedures in office first, maximize any improvement, and then see where we're at in terms of the patient wanting to proceed with additional treatments. And the plan does evolve over time as the patient ages, as the condition changes, and after a sort of alignment of goals between the patient and surgeon continue. So the reason that recovery can take a while is that nerves grow slowly. So think about 1 millimeter a day or an inch a month. Facial retraining, facial therapy sort of improves that movement, and that often goes with all these procedures. And in terms of sort of aligning goals and expectations and maximizing quality of life, improvement is often gradual but incremental, meaning that we can make small changes, but we can continue to make them. They'll add up and compound over time. And then again, incremental improvement is the goal. All right, so what can patients expect? So improved symmetry, better eye protection, and returning of smiling movement are the three primary sort of physical items that we can offer. And then really this leads to improved quality of life, which is the goal of any of these interventions, is to make life easier, more enjoyable, and with a better quality. So hope and next steps. So modern facial reanimation offers many options. It's evolving year by year. So in 5 years, we'll have additional tools that we don't have now. It's come a long way, but it's continuing to improve. And then each treatment plan should be highly personalized. So no two patients should have the same treatment plan. It should be tailored to your goals and the surgeon's expertise. But it's also very important to find someone who specializes in this area. It's an up-and-coming field, so finding someone like our team here at the clinic is especially important to being offered the full breadth of options for treatment. Thank you.